Hey everyone, welcome to this Ward Rounds Explainer. Today, we're tackling the high-stakes clinical reasoning you're going to need to defeat some seriously difficult enterococcal infections. If you're a med student just stepping onto the wards, listen up, because these pathogens are going to test absolutely everything you know about pharmacology and microbiology. We're zeroing in on the treatment choices for the most stubborn infections you'll actually see in practice. Let's get right into it.
Here's our SOAP-style workup for today. We'll start with the clinical threat, compare our main suspects Ficalis and Phyceum, decode vancomycin resistance, look at advanced resistance mechanisms, formulate a treatment plan, and wrap up with the absolute clinical red flags. Quick and painless, let's move on.
All right, Section 1, the clinical threat, nosocomial infections.
Picture this. Your patient just had a TAVI procedure, a transcatheter aortic valve implantation. They're recovering in the ICU, looking good, and then bam! They spike a sudden fever, their blood pressure absolutely tanks. You see, these bugs are notorious for causing severe community and hospital-acquired endocarditis. And when a critically ill patient develops a nosocomial enterococcal infection, well, they face significantly worse outcomes, mainly because our treatment options are just so incredibly limited.
So put yourself right there in the hospital, you're on ward rounds, your pager goes off, and the microbiology lab tells you there's a positive blood culture for Enterococcus. What is your very first diagnostic move? I want you to think like a clinical detective for a second. Before you even think about reaching for your prescription pad, your entire treatment strategy hinges on one critical thing. You have to identify the exact microbial suspect. We need speciation, and we need it fast.
Moving to Section 2, Ficalis versus Phyceum suspects. This is our microbial lineup. Now, why does speciation matter so much? Well, Enterococcus faecalis is the most common player. It makes up the majority of isolates. And the good news? Ampicillin resistance here is actually pretty rare. But then we have Enterococcus faecium. This one is rising rapidly and now causes about a third of these infections. And honestly, the terrifying part is that over 90% of faecium isolates are completely resistant to ampicillin. How? They use an altered PBP5, which has super low affinity for beta-lactams. That means the bug just keeps synthesizing its cell wall right through your ampicillin dose. Ampicillin, imipenem, ureadopenicillins, against most faecium, they're basically useless.
Okay, Section 3. Let's decode vancomycin resistance, or VRE. 80%. Let that number sink in. While vancomycin resistance isn't super common in Ficalis, it hits somewhere between 50 and 70% in acute care settings in the US for Ephysium. But if you step into a long-term care facility, that staggering 80% represents the upper limit of VRE frequency in Ephysium isolates. It's a massive hurdle.
You've got to memorize these mechanisms, not just for the boards, but to actually survive on the wards. We're looking at three main types of vancomycin resistance. First up, Van-A. This involves a D-ala to D-lactate substitution in the peptidoglycan precursor, driven by a transferable plasmid. It drops vancomycin affinity by roughly 1,000-fold. So you get high-level resistance to both vancomycin and teicoplanin. Then there's Van-B. Same substitution, but here's the kicker. While it's vancomycin resistant, it actually stays teicoplanin susceptible. Huge clinical pearl right there. And lastly, Van-C. This is an intrinsic chromosomally encoded D-ala to D-serine substitution. It causes low-level resistance, but it's restricted strictly to specific species like E. gillinoranum and E. cassella flavus.
Section 4. Advanced resistance mechanisms. Let's look at their evasion tactics. These bugs are sneaky. They use some highly advanced evasion tactics. First is HLA-R, or high-level aminoglycoside resistance. This happens via aminoglycoside-modifying enzymes or ribosomal methyltransferases, and they completely abolish the synergy you'd normally get with cell wall active agents. Next, prolonged exposure to linezolid, that's leading to emerging resistance through transferable 23S RNA mutations and genes like CFR, OPT-RA, and POXT-A. Finally, we're seeing daptomycin resistance, mostly in Phyceum, through LIA-FSR mutations. It's essentially a cell envelope stress response that decreases membrane binding by actually changing the bug's phospholipid metabolism. Pretty wild, right?
All right, time to pimp the team. Let's run a difficult clinical scenario based on that HLA-R mechanism. Your patient's isolate mutates, showing high-level aminoglycoside resistance to both gentamicin and streptomycin. Your attending looks at you and asks for the next move. What are you going to do?
Here is your answer. If an isolate is resistant to both, the absolute crucial takeaway is that zero aminoglycoside synergy is possible. None. If it was just HLAR to gentamicin, sure, you could test streptomycin. But if both are resistant, the synergy is totally abolished, and you have to pivot your entire strategy to dual beta-lactam therapy.
Which brings us to Section 5, formulating a treatment plan, the regimens. Before I just hand you the answer, I want you to really think clinically about this. What regimen has proven most effective for Enterococcus faecalis endocarditis without completely destroying your patient's kidneys in the process?
It's ampicillin plus ceftriaxone for 6 weeks. That is your absolute first-line treatment. This optimal choice relies on dual beta-lactams. Now, ampicillin plus gentamicin is technically an alternative, but honestly, it is significantly more nephrotoxic. We really want to protect those kidneys while we're clearing out the infection.
Now, what happens when we're dealing with the much scarier VRE endocarditis? If you're staring down a vancomycin-resistant strain, these are your precise, FDA-approved steps to stabilize that patient. Step 1. You've got to use linezolid or high-dose daptomycin, and by high dose, we mean at least 10 milligrams per kilogram. Step 2. Medical management alone often just won't cut it, so you must simultaneously evaluate the patient for a surgical valve replacement. Speaking of that daptomycin dose, here is a golden rule. Never, ever underdose daptomycin for E. faecium. The Clinical and Laboratory Standards Institute explicitly mandates high-dose daptomycin. We're talking greater than or equal to 8 to 12 milligrams per kilogram. The guidelines are incredibly strict about this because you need that high dose to overpower those cell envelope stress responses we talked about earlier.
Finally, Section 6, absolute clinical red flags. These are your never events. You need to burn this rule right into your clinical memory. Never use a cephalosporin alone to treat an enterococcal infection. Cephalosporins are just not active against enterococci as monotherapy. It's an intrinsic resistance. Listen, it literally doesn't matter what the in vitro lab MIC results might trick you into thinking, a single cephalosporin is going to fail your patient.
Along the exact same lines, using an aminoglycoside by itself is a definitive never event on the wards. Yes, they can be used for synergy, exactly like we discussed, but aminoglycoside monotherapy? Absolutely never.
And here is another massive pitfall. Tobramycin should never be used for E. faecium. It's a critical trap that so many young clinicians fall into. While the most common aminoglycoside modifying enzyme for gentamicin also covers tobramycin and amikacin, there is a very specific, unique reason you must avoid tobramycin at all costs when you've got a faecium isolate.
And that reason is this. Every single strain of E. faecium possesses a chromosomally encoded tobramycin modifying enzyme. Every single one. Because this resistance is built right into the chromosome intrinsically in all strains, tobramycin will simply never work against E. faecium, period.
Well, thanks for joining this explainer. As you've seen today, these bugs are putting on an absolute masterclass in microbial evasion, constantly adapting against our strongest therapies. So I want to leave you with this final thought. As you head back into the hospital to face these incredibly stubborn pathogens, with resistance profiles continuously shifting, how are you going to actively adapt your daily clinical reasoning to always stay one step ahead? Keep questioning the data, keep relying on speciation, and for sure, stay vigilant out there. See you on the wards.